you so much for having me.
Oh, thank you. Thank you so much. I'm going to officially welcome you. So, welcome to another episode of the Swallow Talk series, where we bring together clinicians, researchers, and educators to explore important conversations in medical speech language pathology. However, I'm so excited for today's guest because we are going to expand our conversation beyond dysphagia advocacy. Basically, my talk series is all about dysphagia, and focus on another incredibly important area of our profession, which is cognitive communication and neurorehabilitation. So today, I'm excited to welcome Renee Garrett, a certified brain injury specialist, obviously CCSLP, and is the founder and owner of Brain Bridge Connect, a private practice specializing in brain injury rehabilitation and cognitive communication intervention. She's a licensed speech pathologist with advanced expertise in cognitive retraining following acquired brain injury, including traumatic brain injury and concussion. Renee also holds, I already mentioned that, a certified brain injury specialist credential through the Brain Injury Association of America and is an experienced national presenter on neurorehabilitation and cognitive communication disorders. She also is the host of the podcast Brainstorms, Functional Neuro Rehab for SLPs. I absolutely love that. I kind of watched and also listened to a few of the episodes, and it was so brainstorming and so amazing.
Thank you. I love it. It's my the title came to me in the middle of the night, like 4 a.m. I had actually, as we say in the South, I had put a prayer on it because I was trying to come up with a name and I didn't like anything that was being given to me. So um it kind of mashed together the right way at the right time. So um
It
yeah, I
totally
really
it
love it.
relates to it.
Yeah, I
Nice.
really love doing it. It's such a fun way to, meet, not only network and meet new people, but just to have, have people come on who can share their expertise and really break it down into digestible things for other SLPs and SLPAs and students. And we even have some OTs who listen, so and some physicians. So that's been pretty cool too.
Amazing. That's right. Yeah. It's beyond networking and also you're sharing your expertise with so many people. It's a great way to kind of help our SLP community. So I absolutely love that. And thank you for doing it.
Yeah, thank you.
So, in today's conversation, I just wanted everybody to know we will explore the role of SLPs in functional neurorehabilitation, the importance of assessing narrative communication and cognitive linguistic skills, differences in evaluating approaches across acute care and post acute settings. And I love that you worked in different settings, and then you can bring your expertise as to how we can evaluate and how we can continue to build confidence and competencies in cognitive communication assessments and treatment. So, Renee, thank you again for joining me today and sharing your experience and expertise in our Swallow Talk community. I'm excited for this conversation, as I already mentioned, and the opportunity to learn from your experience. So, I'm going to jump right in with the first question, and that's like one of my favorite questions. So, many clinicians associate acquired brain injury rehabilitation with memory, attention, and executive functioning testing. But narrative discourses is such an important functional communication skills. So, why should SLPs assess and treat the narrative language in individuals with acquired brain injury? And how does narrative based intervention fits into our functional neuro rehab?
Yeah, I love this question because I think in graduate school, I learned about doing a narrative language assessment with the Cinderella story, right? We had to break that down and look at nouns and verb usage and all these other pieces and parts that felt very scary and overwhelming at that time because, let's be honest, grad school is a little bit challenging and rough. And I thought to myself as I was doing it, I'm never going to use this. What is this? Why am I doing this? And what I later kind of learned as, we get into the field and we start doing the actual things of therapy, what I learned was that functional communication is narrative based. So when we think about how we communicate, yes, are there times when you say, "How are you? I'm fine." Yeah, that's not really a narrative. That's just an automatic response, right? An automatic question when you see someone. But when you think about things like for us as clinicians, taking a history from a client, or even if if they do have a communication impairment, you're including hopefully their care partner, caregiver, some kind of family member or friend that can kind of give you that background. That's a narrative-based language task, right? When you go to the doctor, you want to have a communication with your medical team. That's a narrative-based conversation. Same thing with us. I think when we are trying to establish rapport, some of the questions that I ask clients lend them to a narrative response. Like, what do you like to do for fun? When you're not sick and you're not in the hospital, or you're not worried about your Parkinson's disease, what are you doing for fun? What's your favorite restaurant? What kind of food do you like? Tell me about your life. What kind of work did you do? All of those questions they're more informal, but they're also rapport building, and they give you an opportunity to assess narrative language without going, read me this Cinderella story. Because yes, is it appropriate in some cases? Sure. But for a less formal approach and something you don't have to buy that's a standardized assessment, that's exactly how I interpret narrative language, by asking a question that's kind of a prompt, right? It's truly is a prompt, and the patient then has the opportunity to demonstrate, are they able to answer in a narrative way using all parts of speech? Are there things that are missing? Like, are they using conjunctions? Are they missing prepositions? Are they missing nouns versus verbs? Is their usage higher in one or the other? There's all kinds of things like that that make it feel less scary. And I love feeling less scared when I'm,
Absolutely.
when I'm working. I don't want to ever go back to the time of the pandemic where every day was a scary day for what, 2.5 years. I don't want to do that. So if I can make it less scary for me, it's also less scary for who you're working with. When we come in the room and uh, we start drilling people with questions, what happens? We don't know each other, especially in acute care. We may not have, every now and then we'll get a frequent flyer patient, but for the most part, we're meeting new people every single time we're at work. And to go in and start drilling someone with very, very standard formal assessment questions is very scary for them a lot of the time. And if they do have a cognitive linguistic impairment or an aphasia, it puts a lot of pressure on them, and then they focus on that and they can't come up with the answer because now they're nervous, and we've kind of tweaked them a little bit. And so there's a lot of ways that you can do that without making it so formal.
That is so amazing. That's absolutely right. Even for us, like I am, like if I'm talking to somebody and I know if it's public speaking or if I am on like being recorded, I would be put on a spot and it would be completely different than actually being having a functional, conversation. And as rightfully said, you can gather so much more. You can gather the attention task, if the appropriate conversations or the answers are towards it, and then you don't have to have a structured task. Because sometimes I've noticed, especially with brain injury patients, they would be perfect on structured tasks. But when it comes to the functional narrative, they'll be like, what, huh? And that's when you figure out that, okay, these are the areas that the patient would need most help with.
Yeah, I actually have a client right now with an acquired brain injury, and one of the things I noticed with her is she uses a lot of circumlocution when she's talking. But if I had done a formal standardized test and never had these conversations with her, I might not have picked up on that. I might have missed it because, like you said, within the structure of the task, she does well. But in day-to-day life, word finding is a problem. Can she use circumlocution? Yes, but she's also very tangential. So you can pick all those pieces up and learn how to incorporate that into not only your goal setting for the patient, and hopefully that's a mutual conversation you have. Because if it's not important to them, they're not going to have the buy-in and they're not going to want to see you. So that's a big deal too.
That is a big deal, right? And it also brings what was I? It just came through. Oh yeah, perspective taking and the
Hmm.
emotional content and the piece of it, where if you know you're really emotionally connected to something, and then you perseverate on it and go on and on. I mean, I'm not sure, but I've noticed that a lot with my patients. So you can
Hmm.
totally demarcate and kind of like understand that where and how things are. So that's another piece that helps when it comes to the narrative assessments that you're doing. Um, my other question was when we talk about the neurorehabilitation after TBI or other acquired brain injuries, what is the unique role of the SLPs? How can we move beyond impairment based testing and focus more on participation, independence, and quality of life?
Yeah, and I think for me, the best way to answer that is maybe break it down in a couple different settings. So I worked in inpatient rehab, which you said is acute rehab unit where you are. Um, it was actually a 50-bed inpatient rehab hospital, so that's all we did was inpatient rehab there. And for those of you who don't know, it's supervised by, it's medically managed. The patient has to have a medical need that prevents them from possibly going to like a home setting, but not sick enough to be in the hospital. So, or an acute care hospital. So, in this inpatient rehab setting, one of the things that was really helpful was being part of a multidisciplinary team where we met weekly about each patient, sometimes twice weekly, with the physician, the pharmacist, the dietitian, OT, PT, social worker, nurse coding manager, all these people who we all got in the room and we shared our perspectives on what we were seeing. Um, Also, in that setting, being a part of a multidisciplinary team, we did have opportunities to co-treat, or you could observe in the gym when you're transferring, patient A to the PT from your office. You can take them down and you can observe what your next patient's doing with OT or PT. You can see, are they having trouble with recall of the steps for a safe transfer? Are they not able to maintain alertness or awareness to accept new instructions, or maybe even something with medications that the pharmacist has come up with, and the physician's trying to run in real quick between therapies and communicate this, or nursing, or whoever that person is. And you develop relationships with these coworkers and team members, and that way they come to you and they'll say, hey, I was doing this bed skills or mat skills or whatever you want to call it with Mr. So and so, and I noticed that he gets like the first step, and but he can't initiate a task. He can tell me verbally, but he can't initiate a task. And so we can have this conversation about maybe apathy or decreased motivation. And there's just so many ways that you can, look at it, and it doesn't always have to be formal. I think we get stuck sometimes, especially less seasoned clinicians or clinicians who are moving from a different practice setting to something else. You get kind of hung up on, I have to purchase these assessments. I have to get this. My pediatric clinical instructor, when I was a student, said to me one time, she was like, you are so interesting. And I was like, okay, I don't know. Is that a good thing or a bad thing?
But
She's
yeah.
like, she was like, you literally could pick up a magazine and do therapy with someone, couldn't you? And I was like, yeah, I could, because you can, again, it's a printed material. You can use it for anything. You can use it for auditory comprehension, paragraph recall. You can have them read to you, copy this written what do you call headline or subtitle or whatever it is. It's just our job is already so challenging with all these things that we need to know, and these pieces that are tugging at us, and productivity and all this other stuff, that we don't need all that extra fluffy worry stuff.
No, but that also really brings up that you're an expert, so you don't really need a lot of things. You can just pick up literally anything and then make it task based depending on what you're
Mhm.
assessing. And that's so amazing.
Yeah, and like with OT, we would go in the kitchen and either do like help them with they were doing a cooking task. They did a lot of that where I was. The other inpatient rehab unit that I worked on, they had a car that someone had donated, and they had the car cut in half so they could practice car transfers. And you could go in there and, talk me through the safety of this, work on sequencing, all those kinds of things that are so important to these patients. Um, and you asked me, not only about the inpatient rehab, but acute care setting. I think it's even more challenging because we're so constrained in time on how much time we are able to spend with the patient. It would be really difficult to do a full-on 1 hour aphasia normed assessment in that setting. So we have other, and I know we're going to talk about assessment, so I'll kind of hold on to that a little bit, but you can do more informal things. One of the things that I changed pretty early on when I was in acute care was, I get handoffs sometimes from the nurses, and I love nurses, don't get me wrong, but sometimes, they're stressed too. They have a lot of patients. People call out sick, and they would say things like, well, good luck with that one. Or they have like six family members in there. Good luck. And I'm like, I would get kind of nervous about that. And then I started thinking, if this person does have a functional communication impairment at baseline, who better to get that information from? I don't know. It's
Exactly.
probably not
Family
in their
members.
chart. Right? So having someone in the room who knows this person is going to give you information that you can use to help assess the patient too. And the other part of that is a lot of times what happens when you get the good luck with that one, no one's talked to them. They go in the room, they, give them their meal tray. They don't ask them if they need help with anything. They don't go in and say to your, 89-year-old dementia patient, no one's come in and say, "Hey, how's your day going?" or "How are you today?" And we do that and we get, "Well, hey, baby, how are you?" It happens all the
Absolutely.
time.
Oh
Yeah,
God,
so
that's
a lot of
right.
a lot of it is opportunity too for us to provide staff education. Was like a side note of what we're doing.
No, absolutely. And education is so vital. And, I feel like a lot of people, I would just go ahead and say it with speech language pathology and our scope of practice. I think a lot of even medical doctors, healthcare professionals, they really don't even know what we do when it comes to cognitive linguistic assessment. So that puts me straight into the assessment question.
Hmm.
Um, so cognitive communication impairments can occur after traumatic brain injuries, of course, stroke, hypoxic injury, tumors, so many other neurological conditions. So
Hmm.
how should SLPs think about assessment differently across population? And how do we differentiate cognitive linguistic impairment from aphasia? Oh, I also wanted to add the dementia population. And if you want to name some of the tests that you use across different settings, that would be amazing.
Yeah, I'll do that too. I think when we're thinking about cognitive communication, a lot of people, especially at acute care, again, we're on a huge time constraint in acute care. We have to get so much stuff done. We mentioned swallowing assessments like MBSs. Some people call the video fluoroscopy, fees. These things take time. They take time for us to interpret. Often, we get patients who are not necessarily going to be staying in the hospital. They might be there for outpatient, and I was responsible in acute care for seeing those patients too, to complete their swallow studies. So, again, those time constraints make it a little bit of a challenge when you see that cognitive communication assessment pop up, especially if you are working in a setting where your sole kind of pressure is making sure this patient can swallow safely. You want to make sure they can eat, take their medications, get them out of the hospital, decrease, risks of readmission if we can have any impact on that. So there's a lot of moving parts that we're not always in control of. So when we see that cognitive communication assessment, especially if we don't have a stroke diagnosis, like the patient came in for a stroke workup and they didn't actually have a stroke per imaging, you might think, oh, well, why did they even order that? Because it's sometimes it's like I've seen it come across where it's like the social worker went to the doctor and had them order it because they're working on capacity or they're looking at discharge disposition and they can't go home safely. And it almost feels like you're being used or manipulated at times. And I'm just being 100% honest. Um,
Agree.
yeah, it is important though, because again, we need that's a point where we can establish a baseline with the client. So, say this person, I live in a place where we have a huge tourism summer because I'm 40 minutes from the beach. We have vacationers here. We have people who get hurt in car accidents. We have people who do have strokes on vacation, and they come somehow wind up, in acute care or wind up in IPR and wind up on my caseload. I don't always have a lot of information about their baseline. Just because they're on vacation doesn't mean their baseline function was, someone who gets up every day, makes coffee for their and breakfast for their family, goes to work, works an 8 hour day, picks up their kids, takes them to gymnastics, does all the parenting things, homework, and all. That doesn't always mean that that's the baseline for everybody. So it's an opportunity for us to establish a baseline for that client at that level of care because guess what? They may go back home, but they may need outpatient therapy. And if that outpatient therapist can get your notes, which a lot of times that doesn't happen, but if they call me, we'll send it. We can do that and be HIPAA compliant and not break that chain of care. I just feel like it's an opportunity for us and it's often a missed one because of the pressures that you feel, but also the ways in which we're maybe not feeling confident and competent because we don't do it often. My background coming from inpatient rehab to acute, I did cognitive communication assessments all day, every day. Yeah, so
Yes.
I was very comfortable with coming up with, a quick assessment. So a couple of quick ones when I'll get back to the functional language or functional cognitive linguistic and aphasia differences. But a couple of quick ones in acute care that I found helpful was I don't want, sorry for whoever authored, I think I won't say. The CLQT, the Cognitive Linguistic Quick Test.
Yes.
It is quick. It is fairly easy to administer. Another one that I really loved, even in outpatient, I really loved because we got cut, our outpatient sessions got cut to 40 minutes. The quick aphasia battery. Um, People say it's difficult to score. If you have the spreadsheet, I don't think it is. You put the numbers in and it does everything for you. Those are both pretty easily and readily accessible. The quick aphasia battery comes in a couple of different versions and it's free. As far as you mentioned dementia, again, having that baseline of what was the patient doing? How many times have you seen in a chart patient with dementia nonverbal and you go in and you say, "Hey, good morning," and they say, "Good morning." That's not nonverbal. It's not nonverbal.
Love that. That's such a beautiful point that you made, and also the continuity of care because we establish the baseline. And sometimes, if I think in my different hospitals that I work at, when they see dementia, they say, hey, patient already is at their baseline, so we shouldn't be doing assessments. But that's where, the continuity of care, but the patient is just here for a workup or anything and might just be discharged, but then at least they might get that help if they go outpatient, if they go to home health. So I love that.
Yeah, because our goal with a dementia patient is always going to be to preserve function for as long as possible while maintaining quality of life. So why are you not? It doesn't mean you're going to see them every day for cognition if they're in there for a broken toe. It means, again, you have this opportunity to establish a baseline for this patient who may need more therapy via home health or outpatient once they leave. There's a couple of cognitive screenings that I don't love, but they are functional-ish. It gives you some information, and physicians are taught this. They love a SLUMS, the St. Louis University
Yes.
Mental Status Exam, and they love a MOCA. Personally, MOCA is not my thing, but I did have sometimes physicians who would write specific orders for the MOCA, and I'd say it's actually a screening.
So
But
absolutely. Maybe
um,
they just know what mocha is. That's the only
yeah,
test
they
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 know.
do. And the BCAT is another one that you can use that kind of has a little bit of a self-assessment built in. Um,
A
the
BCAT.
course,
I don't know about that one. Okay,
the
good to know.
BCAT,
Uh-huh.
the brief cognitive assessment tools.
Oh, okay. Brief.
Hmm.
Okay. Assessment tool.
And
I'll look
then
into.
um, what's the other one? The brief cognitive rating scale is another PROM, so a patient-reported outcome measure that doesn't cost us anything. And then they do also have the functional activities one that's for adults with dementia, older adults with dementia. Of course, the gold
Ooh,
standard kind of for dementia assessment would be the dementia severity rating scale or the global deterioration scale. And the global deterioration scale has been around for a long time, but it's interesting because it really breaks it down by levels as far as impairment goes. And what's interesting is a lot of the time when someone actually gets the formal diagnosis of dementia, they're already at level 4. That's about halfway down to it's 1 through 8. So that's, if again you have the opportunity, maybe they're at a 3, they're having a little trouble, and no one has given it a name, but you have an opportunity there to have a baseline assessment done for that patient.
for that
I
patient, right?
mentioned, yeah, and I mentioned for aphasia, mentioned the um, quick aphasia battery. That is probably the one I use the most. Of course, we've got the ones who take a little bit more time, like the Boston Diagnostic Aphasia Exam and the Western Aphasia Battery, I think are still pretty widely used. Um, Maybe more so in an outpatient setting and in a private practice, maybe even home health, but that's not feasible a lot of the time in acute care. Inpatient rehab, again, I had more time. I had an hour with my patients. If they had been discharged from OT and they needed PT and speech, or they needed OT and speech, then we might get an extra 30 minutes. So I had plenty of time there to um, really do a thorough assessment. Sometimes I could do two because I would call it diagnostic therapy. I wouldn't bill for a second eval, but if I needed more information, I had the opportunity to do that. Um,
I
you
agree.
asked, yeah, you ask about aphasia versus cognitive linguistic deficits. So aphasia, of course, is a language disorder, whether it's impacting expression, so expressive language, meaning spoken language, written language, or comprehension and reading. So we may see a variety of things there with, like I mentioned, word finding, trouble with sentence formation, agrammatism, paragrammatism, word comprehension or comprehension for longer linguistically complex material. So think about how would that affect your healthcare stay? Literacy, your health literacy. If you already have limited health literacy or decreased health literacy, and now you've got an aphasia that's impacting your comprehension, you're not likely to understand that stroke book that gets left in your room. So that's something that I think we all need to be mindful of because we have the opportunity again to break that down by providing education on what aphasia is and what that looks like. Can you imagine? I mean, that's got to be like one of the most scary things in the world to have happen when you don't know about it. Our communities aren't educated on what aphasia is, what it looks like. And so if you've never heard that, I can't tell you how many times an outpatient, by the time I got a patient, they might be 6 months post stroke and they've never heard the word aphasia. And they just thought, what do most patients say? I just thought I was stupid. I've heard that probably 100 times. And,
That,
that's, again, so frustrating.
it is.
And this isn't just an SLP related thing, it's just a lack of community education for preventable health conditions like stroke, diabetes, hypertension, and all those things that can lead to a stroke. So we've got a lot of work to do as a group, as a collective group, not just as SLPs or
Absolutely.
SLPAs or um, our academic friends who are speech language hearing scientists. Um, so a cognitive linguistic deficit, we used to call this just right hemisphere is what I learned in grad school, but it's really not just right hemisphere deficits. It's those diffuse brain injuries. So we think about someone in a motor vehicle crash or someone who has experienced a concussion, what does that mean? Your brain is sitting in this jello-like substance inside of your skull, and if it stops, your brain doesn't stop. Your skull stops, but your brain can bounce back and forth, whether it's front to back, side to side, up and down. That's a diffuse brain injury. It's impacting several different areas. So cognitive linguistic deficits tend to show up as things like trouble with executive function, social communication skills, whether that is reading the room and knowing when to socially communicate correctly, or sometimes you'll see trouble with attention and memory. If you can't attend to something, you're not going to remember it. And think about, again, all of these things that happen, we're looking at therapeutically. The patient needs to do these things in order to relearn their skill set. In the cases of dementia, if they can't attend to something, they're not going to remember. And I'm a big fan of giving examples. And although my mother-in-law is now deceased, my father-in-law, before he passed away, we did a little, I did a talk at ASHA on involving care partners as part of the team. But one of the things we talked about was the things that she did that should have been red flags that stuck out to me as a provider, but for some reason didn't get translated by her PCP until much later. And by the time she got a neuropsychological testing, she had probably been exhibiting signs and symptoms of dementia for over 10 years. So things like leaving the bathroom sink, running upstairs, and leaving the house. She was the worst diabetic, so she would take baked goods from like Sam's Club or Costco with those paper containers, or those giant muffins in the plastic bin, and she'd put them in her oven to hide them, but then she'd forget they were there and she almost set the house on fire a couple times. So there are things like that where safety wise, again, we have this opportunity because safety is part of executive functioning. Disinhibitions. So we think about our patients with TBI or ABI, they might be disinhibited. What does that look like? They might be cursing where they maybe didn't do that before. They might be, if, uh, people say things inappropriate, as my grandmother would have said, like
Yes, that's a
comments.
typical TBI. Yes.
Yes, uh, comments about body parts, comments about, you look sexy in those scrubs or whatever it is. Or sometimes people will even be disinhibited and say, you look like you've gained weight since the last time I saw you. And I'm like, I just saw you 5 minutes ago. What are you talking about? But things
Mm.
like that, where, we can work on that. Was that an appropriate thing to say? That's probably not, a very nice thing to say to someone. And it kind of goes back again to those informal things that we can combine with something like this, the information we get from the CLQT or the information we get from the quick aphasia battery. So, and when it comes to concussions, I think really the one I probably use almost always is the Rivermead, and it's standardized for concussion, and it's wide range across ages. So if you're someone in acute care, you may not have a children's hospital near you. You might have a kid who pops up on your caseload who's high school age, 16, 17 years old, 18 years old, maybe a college athlete where this is their first experience with a concussion, or a lot of times it gets termed mild TBI. Mild TBI is a concussion.
No, it's one of the most under-recognized. Like, I don't get a lot of orders if a patient has concussions. It's a trauma one hospital I work at, and the other one is it's UCSF, but and also like most of the patients would be in their teenage years if they come or got into a automotor vehicle accident,
Hmm.
and then or they had like a temporary concussion or any of that nature, but we never get to assess them at all. So this is a wonderful point that you made, that they
Yeah.
might
Yeah.
they might sit down.
Yeah, because what happens with concussion, especially if it's undiagnosed, is this person now, if they're returning to school or they're trying to return to work, they're having symptoms that may last beyond the typical 2 weeks, 10 days to 2 weeks. And they might move into possibly having a post-concussion syndrome. And again, if you're in an outpatient setting, you might not see them for several months, but they've been struggling. There was a lady I had that the doctor had diagnosed her with mild TBI. She was in a motor vehicle crash where she was T-boned, so she was hit from the side, and she lost consciousness and was medevac to the. She was down in Florida, medevac to the nearest trauma center, discharged back here to home. She was down there taking care of her mom who had just gotten out of the hospital when this happened. And when she got back here, she was like having the severe headaches, hyperacusis, so that real sensation, sensitivity to sound, photophobia, sensitivity to light. She was very emotionally labile. She was crying all the time. She was really struggling, and her doctor said, "You can go back to work in 2 weeks." Well, I'm sorry, that's not a mild TBI. Losing consciousness and being airlifted right there tells me a lot, right, about this patient. Um, and they wanted her to return to work. She had a very high level state job, that required travel, and she couldn't drive. She'd had a seizure. I mean,
My
there's
goodness.
so many things like that where
Interesting.
we are the missing piece of the puzzle because we're the ones who say, "What are you doing? What do
Yeah,
you mean?"
exactly. Yeah. Or unless our friends, our physical therapists or occupational therapists, if they see them, they would be like, hey, put in the orders for cognition. That patient needs to be seen. Otherwise, it just, yeah, it frizzles. Yeah. It falls through the crack and that patient would not be identified or never be seen. And as you mentioned, inpatient acute care is the one where we help. That's why we do all the assessments. So the continuity of care really happens and patients can be seen with the other settings. So that was my next question about different the settings. I think a part of it you already kind of answered, but
Mhm.
also with acute care environment, it's challenging because patients may be medically unstable, fatigued, intubated, or experiencing delirium. That's one of the also areas where
Yes.
we get a lot of orders and we are like, ah, it's delirium. It's like acute delirium, or within the hospital setting, we shouldn't be doing any assessments. But however, missing cognitive communication deficits early can affect the entire rehab trajectory, and that also includes dysphagia management. How should
Yes.
SLPs, right? How should SLPs approach cognitive linguistic evaluation in acute care compared to post-acute settings?
Yeah, again, I think we have that opportunity to establish baseline, but sometimes you advocate for the cognitive linguistic assessment to happen because you hopefully have talked to the multidisciplinary team members like the OT and PT or the CODA or the PTA, and they've said, "Hey, they're not even able to stay awake, or I don't know how they think they're going to send this patient home with no one there with them when they are, falling out of the bed at night, or I got them up today and they were a max transfer with 4 people there." Things like that, where we can go, okay, something's going on here. Was this how they were before? Is this how they wound up in the hospital? Did they have a fall because they were so unstable? And people are like, well, that's not really our domain. Well, but it is, because you can look at it as, if they're likely having falls, what's happening? There's something missing, right? If there's not a true fit, like they didn't break a bone, or there's not something neurologically happening to the physical limb, it could be they're not paying attention to what they're doing. Their setup in their house is unsafe. We can run through those pictured scenarios, those old school, the man with the car and he's got the beer and the cigarette. And there's
Yes.
no hands on the wheel. Because guess what? How many times do you see it? Because I see it all the time. This is what I see.
Yes. Most of the times it's usually, yeah, they're on their phones and I hate that. That's like the worst part of
Cindy, where we can say, okay, this is the thing that seems unsafe. How do we address it from our standpoint, from a problem solving situation? Because problem solving, sequencing, organizational skills, those are all part of those executive functioning tasks. So if they're having There's kind of a joke when you're tired, if you've had a baby or you've had caring for someone, or if you're in grad school, you're tired. You're tired all the time. You may be missing sleep. You may have broken sleep. You get up in the morning, and what do? Go to make your coffee and you pour orange juice in your cereal or something like that, right?
Right.
Or, when I like to think I've done this twice this week and I was so mad today. I had a couple things I needed from the grocery store and I wasn't taking the time to write a list. And I was like, I can remember it's only like five or six things, right? I get home on Sunday when I went to the grocery store and I was like, you know what? I forgot like five things out of the 10 I went to the store for. Just write it down. So the next day, Monday, I go to the eye doctor. She dilates my eyes. I can't see a darn thing. The fluorescent lights are killing me. And I go in the grocery store and I thought I got everything I needed, except I didn't get the tortillas that are part of the chicken fajitas that I'm making for dinner. So guess who went to the grocery store for the third time this week today for one thing? Me.
Oh my
So
God.
the point of all that is if you're distracted or if you know it's four items, you're going to get there and you're going to go, I got three. Now I bought potato chips. Now I've bought ice cream. Now I've bought something else I didn't need or want. Trying to remember, run through your brain, what was that thing? And when do you remember the thing? When you pull in your driveway or you walk in your house. So
All
think
the
of
time at
those.
house.
Yeah. So think about that from we do that all the time with higher level educated brains. All this time we spend on, certifications and or advanced degrees. We have a lot of information in there, but sometimes we can't always access it if we're distracted by traffic or the lights for me in the grocery store were killing my eyes yesterday. Um, again, lack of sleep, stress, right? Any of those things impact us. So you can imagine if you have a patient with an acute brain injury, a concussion, a stroke, a dementia patient, you bring them to the hospital. Guess what? Everything's different. The lights are different. The furniture placement's different. The sheets are different. The gown's different. People are different. The wall color might be different. I mean, you could go on and on with your list of things that impact this person who has a cognitive linguistic impairment or an aphasia, whether it's a new aphasia or whether it's a chronic aphasia, right? You're still trying to communicate with unfamiliar people that you don't have that rapport with. And that's where we come in to try to bridge those gaps, if you will, and make this transition from setting to setting as seamless as it can possibly be because we've given this patient the skills that they need. We've educated their caregiver, care partner, family, friends, whoever it is that they want involved in their care. We've done that early. Acute care, it starts. Go to inpatient rehab or skilled nursing. Then they come to outpatient or home health. We have this continuum, what hopefully our patients are able to access. So it's not a one stop. We only do this here, right? We're only going to
No.
do cognitive linguistic assessments in outpatient because we have more time. Well, actually, I had less time because I only had 40 minutes per patient. In IPR, I had an hour. In acute care, I might have 23 minutes. I might have 15. I might have zero. Because again, in acute care, everything happens. The patient's out of the room. They're off the floor for testing. They had an acute change and now they're back in ICU. Um, their insurance denied them a one more night stay and now they're gone. You did think they were going to be gone. Or sometimes they're gone because they expired and they're no longer with us. So anything can happen at any time. And so, again, trying to do our best to establish that link that can go make this next piece of their life easier, better, maintain their quality of life, and give them some hope. Let's be honest, we all could use a little of that these days with everything going on in the
Absolutely.
world. Yeah.
Absolutely. I love that. Yeah, the continuity of care and also post-acute care cognitive communication advocacy is where we should really be working towards as an SLP community.
Hmm.
I really love that point. So this is another one of my favorite questions. Many individuals with mild to moderate TBI they may appear conversationally appropriate, right? I hear this all the time. My OT friend would be like, I just saw that patient is ANO4 and doing well. What are you talking about when I do my assessments? But they struggle with executive functioning, emotional regulation, organization, and return to work demands. So, how can SLP identify these subtle deficits during our quick assessments?
Yeah, and that's a great question. I think again, those informal observations, there's been many times when I've gone where I worked in the acute care the last hospital I was at, it was more rural and they had sometimes a lot of overdose cases, polysubstance abuse. Sometimes it was alcohol. Um, and those patients can hide a lot, right? But if they've got to return to work, sometimes they're going to have to recertify on some things. So think about someone who is a laborer. They might have a certification for some kind of job task that they have to do, or they have to know safety and hazards and things like that at their job. So a lot of times we would look at that piece of what do you need to do to go back to work. And even though you can take care of your bathroom hygiene, that doesn't mean you can do your job. That doesn't mean you can be safe and go pick your kids up from school, because if you've got an executive function disorder, it's kind of like the grocery store example. You might know that your kid's school is here, but you might not be able to take the steps to get there. You might not remember how to get to that place or even to the grocery store, right? You may know that it's up on the main road down the street, but you might not be able to remember how to get there. That was another thing with my mother-in-law with dementia. She was having issues with driving and no one was doing anything about it until she had like her seventh car accident. And then all of a sudden they were like, well, she probably shouldn't be driving. Well, what was your sign? I mean, it's just things like that where we have the ability to look at what is the thing this person needs to be able to do. Are they going to be able to return to work and be safe? And TBI patients often, we have a high military community here, and I have a patient that I had very early on in my career, and that's one of the things with him is still to this day he wound up getting his bachelor's. That was a goal long after I treated him because his accident was several years ago. Um,
Okay.
One of the other things was he was able to go back to work because the work tasks were familiar enough and ingrained enough in him. Even after he got discharged from the military, he got a job that was similar to what he did in the military that he'd been doing for almost 15 years. So he's able to do those automatic things that come easier to him. But things like driving can be challenging if he's tired. He still has issues with sleep. He tries to work out, but sometimes, he's not eating right because he doesn't always remember to eat what he's supposed to eat. And we know that all these pieces are such huge pieces in recovery and longevity for everybody, but particularly in these patients that have experienced TBI and acquired brain injury. But I hear that a lot from people that knew him. Yeah, he seems like he's doing fine. He goes to work, he does this, he does that, but it's a struggle and a challenge for him. It takes him longer to do things. He has trouble still with concentration and attention. Um, the client I was talking about earlier that has an acquired brain injury, she looks great. She can walk. She can pick her babies up. She can go outside and water the plants. But could she go pick her kids up from school? Absolutely not. Can she remember the neighborhood that she grew up in where her parents still live? The name of the neighborhood. It's a pretty prominent neighborhood in my community. She can't remember it. She can't remember things like her brother-in-law, his name. So there's a lot of things like that where, yeah, they look great, they look normal. It does appear to be an invisible thing. What about athletes that we see, professional athletes on TV? They get hit, a concussion, and they pass their concussion protocol because they can say their name and their date of birth and maybe give two other questions, and they're back on the field, and they probably go home and they're like, oh my gosh, I
I
probably should have
cannot
been
do
out there. I'm dizzy and I don't feel good and now I have a headache and I could go on. I could do a whole hour on just that because it does. People tend to go off of this physical ability. They're able to walk, they're able to complete bathroom hygiene. Um, one of the questions I asked the OT that discharged my current client was if she had to use a hot tool to straighten her hair, could she do it safely? No.
Mm,
What
no,
about checking the bath water before she bathes her kids?
great
Could she do
examples.
that? Yeah, because it's people like to use this word higher level cognition, right? I don't think it's higher level cognition. I think it's all cognition and how we translate that into what does this patient need to live their life? To live their life. Can they make a, they were avid texter. Can they read an email? Can they text? Can she text her husband if she needs something?
Yeah, these are great examples, and that's literally where our patients struggle with. And
Hmm.
it's invisible disability is what I call with TBI patients because you
Hmm.
don't see it off the bat, but when you try to assess, especially, professional, that's where you see those gaps and discrepancies in the assessment. And I mean, that's exactly why I wanted to bring this conversation forward because, cognitive communication assessment is more than just asking ANO4 times questions, like the
Hmm.
orientation questions is what I
Yeah.
meant. And
Yeah.
I think most of the times I would step back and say this, but I would still go ahead and kind of say this. A lot of speech pathologists in acute care don't really want to do cognitive communication assessments. They see the orders and they kind of just don't pick up patients, don't assign them to themselves because, as you mentioned, it's complex and there's more to, what we really do as SLPs. So, Renee, I have one really a burning question, I would say. What would be your feedback, guidance, support, all these different words for all acute SLPs who feel intimidated or they don't want to really pick up assessments? What would be your take on that?
Yeah, and I think you asked a question I didn't fully answer earlier when it comes to dysphagia management. So again, that's
Yes.
an area where, we do spend a lot of time there, but how are we expecting if we do have to make a complex plan of care for this patient who now needs these compensatory strategies. Maybe they need to have a postural change during their eating or their drinking. Maybe we need to find out from pharmacy, can those medications be crushed or is it safer to take them in pills? Is it there's a lot of nuances, and I think you know where I'm kind of headed with that. But if we are expecting this patient to go home with limited time with us in acute care, because sometimes they're there overnight, sometimes they're there 2 or 3 days. Like I mentioned, sometimes they discharge somewhere else, and we come in and we're like, well, I didn't even.
What to
You
do?
know, I wanted to give them the written swallow instructions that I didn't have time to type up yesterday, which that probably wouldn't have been true because I always had like a standard one I could give people, and then just like check the boxes. But how are they going to understand that information, much less implement it, if we are not spending time, if we notice something is off when we're talking to them? Have them repeat it back to you. If you give them an instruction, even if it's like,
Back approach.
take small sips. And I hate that one, but no one's taking a small sip, not even me. But whatever the suggestion is that you saw on based on your instrumental exam, because I am not a big proponent of let's do this at the bedside and hope for the best and toss a dart at the wall and hope we hit the bullseye. You need to have the instrumental exam, but how are you going to explain that to a patient when you know that one, they can't attend, maybe they have low vision, maybe they have low hearing. All those things impact their ability to attend, their ability to recall, because if they didn't hear you or they didn't see it, they might not know what the heck you're talking about. So, how are your patients who can be so complex? Or think of a head and neck cancer patient. That's a lot of complex medical things going on at one time. How are you expecting them to add one more thing in there and recall it and do it, implement it, if you notice they're not doing it here and they can't teach it back to you? So that's a good reason. If you notice something that seems off, talk to the physician or nurse, find out if there's a new medication. Are they having pain medications that are impacting their day to day or their ability to participate? Or is it an acute change? Because that's another way. If we notice in a cognitive thing that's different or new, that could be an acute neurological change that maybe no one else has picked up on. So that's a good space to maybe do a cognitive screener that you can do in 10 minutes. You don't have to spend
An
a full
hour.
on 45 minutes, hour doing a standardized assessment when you, even though they might not give you everything you need, they might give you enough, right? Something like the slums or the mocha. Ooh, I don't like the mocha, but something like
Me
that
too.
that's relatively quick. It still gives you data, right? It gives you information, and then you can go, oh, this person's not going to be able to remember how much thickener to use for mildly thick or moderately thick liquids when they can't even tell me where their glasses are or what a glass is used for in the case of a dementia patient.
Absolutely. No, definitely. Amazing. Beautiful examples that you put up that I myself would be like, okay, yeah.
And also, don't ask me if I'm in the hospital and I'm a patient, don't ask me what day it is or date. I'm probably going to be in the general ballpark, but if I've been sick, I'm probably going to be like, I don't know,
I
let me
don't
look at my
know.
phone. I'm going to look at the whiteboard because I'm going to cheat. It's not really cheating, it's using your cues, but still your environmental cues, but still, I don't think that that's an accurate measure. If someone can say, it's like right then I had to look. It's Wednesday, July 29th, 2026 in the afternoon here in Virginia.
Yeah,
I had to look at the date 3 times today, even though I know I should have known. I
right.
don't sit around
Right.
talking about today is July 29th. So.
Yes, exactly. Great, great, great example. Absolutely. Oh God, I feel so bad for our patients when we go in and say, what's today's date, month, location, time, situation? It's like automatic, and sometimes patients get so annoyed. Why you keep asking me the same
Do.
questions? Because I think most of the time the residents, the doctors, or the nurses must have already done their, the Q4 quarter four neuro checks that they do. Must have asked them
Yeah.
100.
Well, and what they when they say that to me, this is what I would say. I always said that's so that we can all make sure you tell us the same answer because it helps us know if you've had a change in your status. And when you say that, they're all like, "Oh, okay, cool," and they're fine with it. Um, and then the other piece of that was, I think I lost my train. Um, yeah, if you go in and you startle wake someone, that's not the first question I'm going to say is, you know, I've seen people go in and say, "Where are you?" And they're like, "I'm in the hospital." Which one? Who
Oh my
cares?
God, yes.
Who cares? They got it right. They're in the hospital. They know they're in the building that's a hospital. It's not the library. They didn't say I'm at the grocery store.
That's enough for you. Oh God, that was so right. Yeah, nurses do that all the time. A lot of, even at times I've done that. Oh, yeah, yeah. So, great, great, great conversation, especially about the dysphagia management. Like you said, the cognitive communication deficits totally can impact dysphagia
Yeah.
management. So,
Hmm. And follow-up
and
care too. Yeah.
follow-up care too, yeah, because they have to remember their own compensatory strategies, their own safe swallow strategies, or what we keep reminding them, as you mentioned about the teach back approach. And they would be like, oh God, this is another layer that I have to remember. So totally agree. But circling back to the same question about what would, like, I just want like everybody to have more confidence in doing these assessments,
Mhm.
especially in acute care for SLPs. What would be your suggestion for or feedbacks for them, for us?
I think when it comes to competencies, we certainly have access to low cost or no cost things like podcasts that are for ASHA CEUs, like mine is for CEUs. So if you listen, you can take the little quiz at the end and you can learn more because we're having more people in spaces that are more approachable. You can listen in your car, even if you don't do it for a CEU. Maybe you learn something new from that person who is an expert witness, a subject matter expert. Sorry. That's one way. I think a lot of state associations will have occasionally a low cost talk to that they maybe invite someone from another state. Some state associations have lower costs in their conferences and maybe offer reciprocity if you have a neighboring state. Say I'm a member of Virginia and I want to go to North Carolina, I could check and see if maybe I can go to their conference and maybe get some more competencies. And there's a speaker there I really want to see. I think too, not relying so much on social media. There's a lot of TikTok and Instagram and things like that. And while that can be a good source if you vet that source, it's not the beat all end all. That could be misinformation and pseudoscience. Um, there are a couple places where if you really are into research and you want to read about that, Speech Bite out of Australia, they actually vet research for you. You can go on their website, SpeechBite, I think it's .com, and you can type in whatever the subject is, and it'll pull up vetted articles that are they have validated to make sure that's a valid study. The study design was there. You don't have to do all that work if you just wanted to read about, say something you haven't seen before, or maybe you want to start looking at expanding your tracheostomy program. How could you learn more about that and feel more comfortable? It's the same thing for that it would be for cognitive communication. You could vet something through them. The informed SLP, I think you get I think it's one free review a month. And you can pay for more if you want to, but that's another resource where they have several different people who are looking through these research articles and making sure they're not pseudoscience. Um, and honestly, if you like when I started the podcast, I was swinging for the fences. I still do. I reach out to people and I say, this is what I'm doing. I'd love to talk to you about this. And some people want to meet beforehand and kind of run through some things. Many people that are thought leaders in our field or mentors in our field are very open to conversations that they share their experiences with. And I think for me, that's been so helpful because there's so many people, not just in the podcast, but even before that, that I would reach out to and say, hey, I have this complex case. Can you tell me what your thoughts are? What am I missing? What am I doing wrong? And we may not always want to be doing work outside of work, but sometimes we don't have space in our day that's a paid space that we can do that. It's hard to do that when you're working in healthcare because of the productivity standards and the health systems want to make their money. So they're not going to pay you to
Absolutely.
call the neuropsychologist and brainstorm about this patient, but you could totally develop those relationships on your own. So that would be what I'd say to that are free, low cost. Maybe it feels intimidating, but I like to connect people. So I think when we make
Same.
these connections, yeah, you might know somebody that knows something that I might need, and I might know somebody that knows something you might need. And so I always try to keep those channels open and don't burn bridges. I say this to my students, you never know who's going to be interviewing you, and you never know if you're going to be interviewing that person. And maybe you don't really hang out and go get coffee or wine or whatever, but you need to have that professional connection that's you're able to keep that judgment, that objectivity separate from maybe the personal thing that
Personally,
was unpleasant. Yeah.
I
But yeah.
love it. No, that is so beautifully put and so amazing, Renee, that you mentioned. Actually, Dr. Bonnie Martin Harris, I had my second conversation with her, and I was so excited, but I was so nervous, we've talked about and we've heard about MBSs and so much, and I was like, she actually mentioned this that you don't have to be an expert, you don't have to be a dysphagia expert, but you need to know everything. And she brought that
Mhm.
a beautiful example about feeding an infant. You're not just doing dysphagia therapy or a feeding therapy, but you're also doing speech and language. You're doing a language
Mhm.
enriched environment therapy. So it all really it overlaps. Our field is so amazing that you can do so much with just one task, but you can see a lot of areas of expertise. And also that helps with your networking because, you never know what can happen and who you would run into. And you need to have that professional boundaries and despite of whether you like the person or not, but just to kind
Hmm.
of have that community
Well,
based.
and one more thing to add to that, the mentorship piece. I think it's hard to have an individual mentor again because of the productivity standards. Some places do encourage that, but there are formal mentorship programs under things like ASHA, in Basel, the National Black Association for Speech Language Hearing. They have a mentorship program. They've got BEAM is another one. And I can't remember what that stands for off the top of my head. Some state associations have mentorship programs where people will volunteer to mentor.
Yeah.
It doesn't have to be a student. It doesn't have to be a CF. It could be, say, I wanted to go into pediatrics. I
Pure.
don't.
Yeah.
I don't. But if I did, I might be able to use that connection to get paired with someone who could provide mentorship. So that's another way that you can, again, this is on your own time, but if it's something that's important to you, and you feel strongly about, or even if you don't, maybe you're just scared. Sometimes scared is that thing that puts you out of your comfort zone. And for me, that's when I want to learn more and know more and do better. So I think that's another way that you could possibly get more confidence and competent by seeing what someone else's experience has been like.
Absolutely. This is one of the most valuable skill sets that speech language pathologists can develop, especially when working with individuals, as you said, acquired brain injury, neuro deficits, dementia. But our role extends like far beyond swallowing, communication, cognition. But at the end of the day, it's helping people regain the ability to communicate, think, participate, and connect with the daily lives. So
Yeah.
thank you, Renee. This was so amazing, eye-opening. I think I learned a lot. I took so many notes about the assessments.
Oh,
Because
good.
working in thank you. Working in acute care, it was really, it's hard to triage certain
Yes.
areas and all of that. But hopefully, I'm going to incorporate all of this during for my cognitive skills development, and also hopefully help all the patients who really need these assessments and also treatments.
Yeah. Thank you so much for, again, having me, inviting me on. I love talking about, as you can tell, I love talking about this kind of
I
stuff. I'm passionate about it. So,
I love having guests on my talk who are really actually passionate and not just here for the talk, and with conversations you can actually tell like how much you really want to talk about things. For me, I jump from one point to the other and I'm like all frazzled in my head. But thank you again for coming here and taking the time for my audience, besides and beyond swallowing and dysphagia advocacy.
of course, of course. Thank you.